Hello everyone, I am Dr. Barashkar and today we will be discussing an important topic that is respiratory failure and oxygen therapy. I will start with the clinical scenarios. The first scenario is a 65-year-old male with acute MI having respiratory rate of 26 per minute and saturation of 96. So for each scenario, you have to decide whether you need to give oxygen or not, and if you need to give oxygen, what is the best device to give oxygen and at what oxygen flow will you start. And the second scenario is a 70-year-old male chronic smoker with dyspnea, respiratory rate of 30 per minute and saturation of 86% on room air. And the third scenario is a 20-year-old female type 1 diabetic with vomiting, respiratory rate of 30 per minute and saturation of 98% on room air. And the fourth is a 55-year-old previously healthy male with fever, productive cough, BP of 85 by 50, respiratory rate of 28 per minute, and saturation of 80% on room air. So, learning objectives are simple: define respiratory failure and understand its types, how to assess and manage it, review oxygen delivery methods, and emphasize routine roles in care. Respiratory system: the main role of respiratory system is to take oxygen from inhaled air and absorb it and provide it to the tissues. Carbon dioxide elimination is the other important role. So this picture shows how oxygen gets into the blood. Air comes in from the airways, which is the alveoli. Oxygen is absorbed in the blood vessels, and carbon dioxide is taken out. Diffusion method, and this carbon dioxide is removed through the airways. This is a very simple diagram showing the working of respiratory system, the lungs. So when will you say that the patient is having respiratory failure? This depends upon their oxygen levels, um, the inability of lungs to maintain adequate gas exchange, respiratory failure, oxygen if it is less than 60 millimeters of mercury, or carbon dioxide if it is more than 45 millimeters of mercury. These are the types of respiratory failure. If it is only oxygen which is low, then that is type 1 respiratory failure. If carbon dioxide is high as well, then that is type 2 respiratory failure. Both of these respiratory failures can be acute or chronic. The examples of type 1 respiratory failures are pneumonia, ARDS, or pulmonary embolism, while the examples of type 2 are COPD, CNS depression, neuromuscular disorders. As I told you earlier, both can be acute or chronic. This is the control of the breathing system or the respiratory system. It is controlled by the CNS through the peripheral nerve, and the respiratory muscles and chest wall plays an important role in the mechanics of the respiratory system. Airways transfer oxygen and air from the environment into the lungs, from where the gas exchange takes place in the alveoli. So the first four of these components, they constitute the respiratory pump, while the alveoli are the places where gas exchange takes place. The type 1 or hypoxemic respiratory failure is when we say PaO2 is less than 60 milliliters. Is the most common type of respiratory failure. It is caused by alveolar filling. This when the alveoli become filled by fluid in case of pulmonary edema, or with pus in case of pneumonia, with blood in hemorrhage, or when the blood supply to the alveoli is blocked due to pulmonary embolism, the oxygen cannot be absorbed and it cannot be taken to various tissues. So these are the type of respiratory failure. The pathophysiology is different if there is alveolar hypoventilation or there is a ventilation perfusion mismatch. As I told you earlier, in case of pulmonary embolism, there is a ventilation perfusion mismatch or there is a shunting. The air, the blood from right side of the heart goes to the left side of the heart, bypassing the lungs. These shunts can be in the heart itself as well as in AST or VST. or they can be in the lungs in the form of AV malformation. So the deoxygenated blood does not reach the alveoli for oxygenation. Or there can be limitation of diffusion. The oxygen cannot be absorbed through the alveolar capillary membrane. The second type of respiratory failure is hypercapnic respiratory failure due to increased carbon dioxide in the blood. Usually, the ventilatory supply is much more than the ventilatory demand, and around it is 10 to 12 times more, and the body is able to compensate and meet the increased ventilatory demand in most of the cases. But when the lungs are damaged due to any disease and the demand becomes excessive, the ventilatory supply is unable to match it. That leads to hypercapnic respiratory failure. Certain anomalies of the central nervous system, like sedation due to any reason, whether that is due to narcotic or due to CNS disorders like meningitis, tumors, or strokes, or AV malformations, or vascular pathologies, or metabolic derangements like severe edema, hepatic failure, and advanced uremia, they can all present as type 2 respiratory failure. Similarly, when the control of the breathing system is damaged due to anomalies of the peripheral nervous system like GBS, myasthenia, polymyositis, certain muscular dystrophies, ALS, and metabolic disorders, then similarly the type 2 respiratory failure occurs. Similarly, in case of chest wall abnormalities like kyphoscoliosis, plain chest, extensive thoracoplasty, or morbid obesity, and massive abdominal distension due to ascites, this exerts pressure on the lungs. The lungs cannot expand completely, and this is a restrictive type of defect leading to type 2 respiratory failure if it is chronic. Central airway or lower airway obstruction, upper or lower airway obstruction can also cause respiratory failure. It can be due to foreign body, inhalation, tracheal tumors, or compression of the trachea from outside even. Similarly, lower respiratory airway pathologies like COPD, asthma, cystic fibrosis, and bronchiolitis can also cause type 2 respiratory failure. Type 1 respiratory failure, the abnormality of the alveoli, which we have already discussed, usually called type 1 respiratory failure. Clinical features are due to respiratory failure and can be dyspnea, restlessness, headache, confusion, drowsiness, and there would be some signs or symptoms of underlying disease, like, for example, pneumonia, or pulmonary embolism, or heart failure. The diagnostic approach: first, you should suspect on the basis of clinical assessment when the patient is dismissed that the patient may be in respiratory failure. And screening is done by pulse oximetry, ABG is done to confirm the diagnosis, and then you should always look for the underlying cause of respiratory failure. Pulse oximetry is a screening, ABG is confirmed, chest X-ray to look at the cause, other investigation to look at the cause and severity of respiratory failure as well. So ABGs are very important in respiratory failure. In nervous system disorder, the pH will be low, PCO2 will be high, there will be type 2 respiratory failure. In airway disease, in acute asthma, initially it will be type 1, but when there is respiratory muscle fatigue, then it can convert into the type 2 failure. Similarly, in COPD, both type 1 and type 2 failure come, can be seen. Alveolar disorder, usually type 1 respiratory failure, but once there is respiratory muscle fatigue, then there is type 2 respiratory failure. How will you decide where you want to treat the patients having respiratory failure is depending upon the severity of the respiratory failure and how quickly it has developed, how bad is the hypoxemia, hypercapnia, and acidemia, and whether the patient has got comorbid conditions like heart failure, like heart disease, or renal disease. Then you can decide whether to admit patient in the ward with monitoring or admitted in the ICU. COPD patients usually have type 2 respiratory failure and it usually responds well to NIV. If the acidosis gets resolved quickly within 1 to 2 hours, then the patient can be admitted in the general ward as well. Management is simple: support ABCs, airway, breathing, and circulation, start oxygen, monitor response, use NIV or when ventilation is needed, and always treat the cause. If the cause is not treated, the patient will keep on getting fatigued and the respiratory failure will worsen. Oxygen therapy is a treatment for hypoxemia. It is not a treatment for breathlessness. So all the scenarios which we discussed in the beginning, if the patient's saturation is above 94%, they do not need oxygen. The absolute indication is PaO2 less than 60 or saturation less than 90. Severe trauma, patient needs high flow oxygen. Severe acute anemia, acute MI with hypoxemia. If the patient with MI does not have hypoxia, they do not need oxygen. Low cardiac output with metabolic acidosis and hypotension. So maintain target of 94 to 98% in most patients with the type 1 failure. If the patient has type 2 failure with high PaCO2, then the target will be 88 to 92%. These patients are usually in chronic type 2 respiratory failure. There are certain devices like nasal cannula can be used to give oxygen up to 2 to 6 liters per minute. If higher flow is needed, then better to use face mask. Simple face mask can give 6 to 10 liters. And for the patient who presents with shock, sepsis, and saturation at concentration is below 85%, treatment should be started with a reservoir mask, the non-rebreather mask. If an oximeter is not available, give oxygen as above until oximetry is available. If the patient have coexisting COPD or risk factor for type 2 respiratory failure, then the target should be 88 to 92%. The main risk factors for type 2 respiratory failure are previous history, severe or moderate COPD, patient on long-term oxygen or home, non-invasive ventilation, patient having severe chest wall or spinal disease, neuromuscular disease, severe obesity or OHS, and cystic fibrosis patient. So nasal cannula, 1 to 6 liters, FiO2 can be 24 to 40%. For a higher FiO2, you can use simple face mask. Even higher non-rebreather mask, especially in unstable septic patients in shock. And high flow nasal cannula can be used for high flow of oxygen when the patient is not maintaining even on non-rebreather. It provides low dose of PEEP up to 5 centimeter of water as well. Still, if the patient is not able to maintain, you can use an IV, and beyond that, invasive ventilation can also be used. Venturi mask can be used to give controlled oxygen supply, especially in patients with COPD. They are of different color, and um, each one of them provides oxygen at target flow and target concentration as well. High flow nasal cannula has been used for last few years. It provides flows up to 60 liters per minute. The air is heated and humidified. It not only improves oxygen but reduces the work of breathing and prevents intubation in some cases as well. Monitoring is very important because these patients are quite critical. Type 1 patient can go into type 2 failure type and they can worsen further as well, needing invasive ventilation. So continuous monitoring of vitals and oxygen and capnography or ABGs is needed. It's a team approach. The management of respiratory system, doctors diagnose and advise treatment, nurses administer treatment and monitor the patient. Respiratory therapists help in setting up the various devices and help in monitoring as well. So better communication is very much needed for a good patient outcome. In summary, you should be able to recognize respiratory failure early on the basis of patient's presentation. their history, and clinical examination findings. You should be aware of risk factors for type 2 respiratory failure, do an ABG, and differentiate between the two because the treatment can be different. Choose device on the basis of acuity of situation, how critical the patient is, and what will be the best device for them. Continuous monitoring and teamwork is important. Thank you.